This
And
conference will now be recorded.
I thought what I would do is just cover some of the basics about DCIS, how we determine whether endocrine therapy even is an option for you, and also some of the controversy that you're probably aware of in terms of, does DCIS really even need treatment? And I think if we can get through some of those basics, then we can have a really informational question and answer session afterwards. So I do always think it's important in these days of transparency. I do not have any financial disclosures or conflicts of interest related to this topic. So what is DCIS? If you look on the screen here, and I'm not sure if you can see my arrow, but you can see the outline of a milk duct, and normally in DCIS, there is just a single layer of cells lining the milk duct. That's this area in the center. But here you can see there is an overgrowth of cells. They're just jam-packed in there. And the cells are not normal cells. These cells have a cancerous appearance. So DCIS is a malignant cellular appearance. And these cells are what we call non-obligate precursors to invasive cancer. DCIS doesn't always transform into invasive breast cancer, although it can. It's been reported that anywhere from 15 to 50% will eventually develop into invasive cancer. And this is without treatment. And what's also important to note is that in patients who are diagnosed with DCIS on a needle biopsy, about 20% of the time, or up to 20% of the time, when we do surgery and remove the area that was biopsied, we actually find invasive cancer. It's not that the needle biopsy wasn't accurate, but a needle biopsy only takes out a small amount of tissue. I explain it to patients that we often go to surgery to make sure what we're finding isn't just the tip of the iceberg. And DCIS is extremely common. It's been reported in up to 15% of autopsies in women who have died from completely unrelated conditions. We see about 60,000 cases of DCIS per year. And the typical presentation is calcifications on a mammogram. So this shows a mammogram of the central portion of the breast. The nipple is seen over here on the left. And all of these little white dots represent DCIS. Now, it's also important to note that when you talk about or hear calcifications on a mammogram, calcifications and DCIS are not the same thing. The DCIS is the changes in the cellular appearance, and calcium can deposit in cells that are cancerous, are DCIS, or have normal features. So the calcium isn't necessarily the problem. The calcium is more of a marker or a red flag that something might be going on. And occasionally we see DCIS present as a palpable mass, a lump that can be felt, but most commonly it's not something that can be felt. It's calcium deposits on a mammogram that signal that something is going on. Now, this shows the incidence of DCIS and screening mammography. And there's no question, because DCIS is often diagnosed by mammography, that the increase in mammography use has led to an increase in diagnosis of DCIS. And our standard treatment recommendations actually are very similar to that for invasive cancer. We typically recommend a lumpectomy. We often recommend radiation therapy. And for DCIS that's estrogen receptor positive, and I'll explain what that means in a minute, we often recommend some form of endocrine therapy, either tamoxifen or aromatase inhibitors. So when we talk about estrogen receptors and estrogen positive, whether it's invasive breast cancer or DCIS, this is what we're talking about. The estrogen receptor sits on the inside of the breast cell. I have it shown here on the outside just because it was easier to draw, but the estrogen receptor is on the inside of the cell. And in the normal situation, normal breast cells have estrogen receptors as well. And in the normal situation, Estrogen that the body naturally produces binds to that receptor and it signals different phases of cellular growth. This is one of the reasons that in premenopausal women with the normal fluctuations of estrogen and progesterone with the menstrual cycle, there's some breast tenderness and swelling. That's in part related to the estrogen effect. So a cancer cell is just a normal cell that has mutated. And many breast cancer cells still have the estrogen receptor, which means they can be stimulated by estrogen. Now, in the cancer setting, we can actually take advantage of that and block the estrogen receptor or decrease estrogen levels to help influence in a negative way cellular growth. ER negative or estrogen receptor negative breast cancers are those that have lost the estrogen receptor in their mutation process. And so we don't have the opportunity to use estrogen blocking medications as part of treatment. And that's one of the reasons that estrogen receptor negative breast cancers tend to be a little harder to treat, is because we don't have the ability to block that estrogen receptor. It won't make a difference in those cancer cells. But the majority of breast cancer cells, whether it's invasive or DCIS, do contain the estrogen receptor. And so we can, in premenopausal women, as you see on the left, use tamoxifen, which essentially sits in that estrogen receptor and blocks it so that the estrogen can't get in to have a growth-like effect. Or in postmenopausal women, after menopause, there aren't high levels of estrogen, but the estrogen that's there tends to come from the fat cells and the adrenal glands. And so we can use medications called aromatase inhibitors, which block the conversion of hormone precursors into estrogen. And that's how they lower estrogen levels, and that's how they prevent or reduce the likelihood of breast cancer recurrence. Now, I mentioned before the two main medications or classes of medications. One is tamoxifen, which again blocks the estrogen receptor, and this can be used in pre or postmenopausal women, generally for 5 years. And the main side effects are related not only to the lack of estrogen or estrogen blockade, which is hot flashes, but tamoxifen is what we call a selective estrogen receptor modulator, or SERM. And so in the breast, it acts as a suppressant, but in the ovaries and uterus, it can actually act as a stimulant. So some of the potential side effects come from that stimulatory effect of the pelvic organs, and that can be ovarian cysts, vaginal discharge, irregular bleeding, and a slightly increased risk of uterine cancer. Tamoxifen is also associated with an increased risk of blood clots. The aromatase inhibitors are only used in postmenopausal women. And there's 3 different medications: anastrozole, letrozole, and exemestane. And what these do is block the peripheral or the production of estrogen in the fat or the adrenal glands. So it completely shuts down any little amount of estrogen that a postmenopausal woman might be making. These medications for DCIS are also used for 5 years, and the primary side effects are related to estrogen deprivation. So hot flashes and all of the side effects that can potentially come with menopause and estrogen deprivation, but they also do accelerate bone loss and can precipitate osteoporosis. And in addition, are associated with a lot of musculoskeletal complaints, such as bone pains, muscle pains, and joint pains. And so getting now to treatment of DCIS, and why do you hear some discussion about should DCIS even be considered cancer, and some discussion of no, we need to treat. And it's because DCIS is not one disease, just like breast cancer is not one disease. The slide on the right side, the figure on the right side on the bottom is that low-grade DCIS, and the one above is showing high-grade DCIS. So the cancer cells have a much more abnormal appearance in high-grade disease. They have more copies of DNA. They have more mitotic figures, so more DNA copies that are actively dividing. And you can see areas in the upper right portion that light pink is what we call chemotonecrosis. So when cancer cells are rapidly growing, they can outstrip their blood supply, or they can grow faster than their blood supply can keep up. And so there are some of those cancer cells that die. And in DCIS, we call that chemotonecrosis. But these two diseases, low-grade versus high-grade disease, they not only look different, but they have very different biological behaviors. So DCIS is not all one disease, but also when we're talking about treatments, we don't all always agree on the endpoints of treatment. What is our goal of therapy for DCIS? Because we know with DCIS, regardless of treatment, the overall survival will be over 97%. But for some women and for some clinicians, survival is not the endpoint in DCIS. The endpoint might be development of invasive cancer or recurrence of the DCIS. So there are a lot of different endpoints that we look at, and different endpoints may be important to different patients and also to different researchers. And we also look at recurrence rates not only of DCIS itself, but invasive cancer. Because we know that if DCIS is treated but then recurs, 50% of the time, the recurrence could be invasive cancer. And then we're not dealing with stage 0 disease, but at minimum stage 1 invasive disease. So for an individual patient and even for her physicians, it can be very difficult to decide what the right treatment regimen is. Any of the treatment decisions require trade-offs. There's not one of our treatments that's not associated with some side effects. And sometimes those side effects can be lifelong and can be, for some patients, worse than the actual disease itself. We don't have a good handle, because it's so individual, on what endpoint is important to patients in general, and certainly don't have a good handle on what endpoint is most important to the individual woman who's newly diagnosed. And probably one of the biggest challenges is we don't have perfect means of predicting the course of disease. We don't know yet which patients newly diagnosed with DCIS today truly can be left alone and their disease will never cause a threat to their life, versus which ones have a disease that is more likely to have a significant impact on their quality of life and life expectancy. So there are various models and various genomic tests that take advantage of tumor DNA to help us predict outcomes, but none of these are crystal balls. But you should be aware that there are various models that are used. The Van Nuys Prognostic Index, the Patient Prognostic Index, and the Memorial Sloan Kettering Nomogram, these are all models that take into account various factors of the disease and various patient factors. So things such as whether it's low grade or high grade, whether there's chemotonecrosis or not. Things like the age of the patient, whether they're pre or postmenopausal, and how much disease is present. Those are some of the factors that get plugged into these nomograms. The Oncotype DX DCIS test and the Prelude DCIS test, these actually do a genomic analysis or a DNA analysis or an RNA analysis, genetic evaluation of the DCIS itself to try and help us predict behavior of the disease. And these are certainly steps in the right direction, but again, we don't have a crystal ball, and all of these tests, even in the patient that scores on the low end of risk, it doesn't mean that they have no risk of their disease progressing. There are several clinical trials ongoing trying to answer the question of what is the right treatment. And can we minimize treatment and its associated toxicities, but still have good patient outcomes? So in the US, the Alliance Cooperative Group has the COMET clinical trial. In the UK, there's the LORIS trial, and then an international collaboration for the LORD trial. The COMET study has a wonderful website, dcisoptions.org, and it provides a lot of information not only about the COMET trial, but just about DCIS in general. And information, as I've touched on, why it's so difficult to pin down a one treatment option that's right for everybody. It discusses the different types of DCIS and provide some information that I think is helpful to patients, even if they're not necessarily interested in the main treatment arm of the COMET study, which is active surveillance. DCISprecision.org is this international collaboration, and again, has a lot of information not only about DCIS, but also about a lot of the ongoing work, especially that focusing on genetic markers and tumor-specific factors, so we can really try and drill down on an individual level, on an individual patient level, and make more precise recommendations for an individual woman's situation. And then, of course, you're probably no stranger to Donna Pinto's website, dcis411.com. I've known Donna now for a couple years. We met as part of the stakeholder advisory group from the COMET study, but she's obviously been an advocate and a patient educator for a long time in this arena. And I wanted to shout out to her website because there's a lot of not only valuable information there, but she also provides peer support, which I think is very, very important. So where are we going in the future? What the hope is and where our trials are taking us is we'll perform imaging, we'll do a core biopsy to make a diagnosis, and then hopefully be able to use various biomarkers and genetic features of the cancer to make tailored and precise recommendations for the individual patient. We will hopefully get away from this recommendation of surgery for everyone or radiation for everyone, because we're getting away from that even in some cases invasive cancer. Why shouldn't we be making the same progress in DCIS? And there's no question that some patients will do just fine without active treatment or with active surveillance. And there is also a lot of work looking at intraductal therapy. So Dr. Susan Love talks about this a lot. Can we identify the duct that has disease and put a small scope in there and maybe put some sort of chemotherapy or estrogen blocking drug in there to kill those abnormal cells, to keep them from proliferating and not need any type of surgical treatment at all? Again, we are headed in that direction, but unfortunately where we are right now is still a lot of confusion, still a lot of, I think, making sure as a patient that you educate yourself, get second or third opinions when needed to make sure you're really getting the answers that are right for you or that you're comfortable with, because we clearly don't have all the answers just yet. And I like to thank you again, thank Deb again for the invitation, and open it up to any questions that people might have.
Thank you, Dr. Attai, for a wonderful presentation. I mean, I guess I'll start by asking you, it's my understanding now they're testing something, I think it's in the test stage, a tamoxifen gel.
Yes, it's actually, I think my first blog post on this when I first saw the article was back in 2014, so it's being tested for a while. Dr. Seema Khan, who is a breast surgical oncologist at Northwestern, has been leading this charge for a number of years, and it is now in multi-center clinical trial stage. And what they're doing is they're using, in patients who are diagnosed with estrogen positive DCIS, who are planning on having mastectomy for various, I believe it's limited to mastectomy patients. I can double check on that. But who are planning to have surgery. They are using a topical tamoxifen gel on the breast. And one of the big advantages is when you're not taking a drug systemically, there's probably some absorption into the bloodstream and into the system, but side effects are much, much lower. And then what they're doing is they're doing surgery on these patients after they're treated with the tamoxifen gel for a period of time to get a sense of, just like we do neoadjuvant chemotherapy in breast cancer and we can evaluate treatment response, they're looking for treatment response. So in early trials of any new breast cancer medication, we always do it in this fashion. Because we need to assess on a pathologic level, did the cancer cells actually respond to this tamoxifen gel? And they've clearly shown that in their earlier phase studies. So they're now looking at that in multiple centers, and hopefully we will get a less toxic form of tamoxifen associated with fewer side effects. And if it is effective in this setting, then maybe we can also use it as treatment for DCIS and potentially eventually as treatment for invasive cancer as well. So I think that's very exciting information.
That leads to another question. Is it possible or true, I'm not sure what the word is, to use tamoxifen or an aromatase inhibitor prior to surgery to see if it can perhaps shrink or just completely obliterate the DCIS? Is that possible? Is that being done?
Yeah, so I'd say yes and no. So we have a lot of data on a neoadjuvant or before surgery endocrine therapy approach for invasive breast cancer. Most commonly, it's neoadjuvant chemotherapy, but in estrogen positive breast cancers and that we want to shrink or downsize before surgery, we can use endocrine therapy, whether it's tamoxifen or the aromatase inhibitors. Typically, what we see at surgery with neoadjuvant therapy is that the invasive cancer goes away, but the DCIS often doesn't. And it's a little bit frustrating sometimes because we still have to do a wide extent of surgery, even though the invasive cancer went away, because we still have to clear all of that DCIS. We may get some answers to that in the COMET study because patients are being treated, those that consent to that arm, with endocrine therapy, and a percentage of those patients will wind up eventually having surgery. So that's one of the endpoints that's going to be looked at there. But we just don't have enough data yet to say that that is an approach that can be done as a standard treatment. I know Dr. Laura Esserman at UCSF has had a neoadjuvant endocrine therapy study, but I believe all of the patients in her trial did have surgery, or in her study are having surgery to assess that treatment response. So it could work based on what we know for neoadjuvant therapy for invasive cancer. It may not work, but it's being studied.
How is it determined if somebody takes tamoxifen or an aromatase inhibitor, and besides just their menopausal status? Are there other factors that are taken in?
The menopausal status is the first question, because premenopausal women cannot take aromatase inhibitors. They just have too high of a baseline level of estrogen, and the aromatase inhibitor just will not be effective. So premenopausal women right now only have tamoxifen as an option. In a postmenopausal woman, we can use either or. We can use tamoxifen or the aromatase inhibitors. For invasive cancer, we gravitate towards the aromatase inhibitors in postmenopausal women because they're more effective in terms of reducing risk of recurrence than tamoxifen in the postmenopausal women. In DCIS, I don't think we have that effectiveness data yet, so we're extrapolating a little bit from our invasive cancer experience. But so in a postmenopausal woman, if you have the option of tamoxifen or aromatase inhibitors, it sometimes depends on a lot of other factors. If you have baseline osteoporosis, probably tamoxifen is a better drug because it can be somewhat protective for the bones versus the aromatase inhibitors, which are anything but protective for the bones. They actually precipitate bone loss. If you have a history of blood clots, then, or if you're very overweight, and especially if you're overweight as a smoker, those predisposed to blood clots, tamoxifen's not a good drug for you. If you have, even after menopause, a lot of uterine proliferative problems, most of the time endometriosis and fibroids tend to regress after menopause, but some patients still have problems with this, then tamoxifen may not be a good option for you. So we take into account not only pre and postmenopausal status, but general medical history and other medical problems. If you start on an aromatase inhibitor and have horrendous joint pains and bone pains to the point where you'd rather just not do anything, then we'd rather at least try tamoxifen to see if the side effects would be better than to stop treatment altogether.
I don't want to ask you all the questions. I'm going to let other people ask questions too.
So I have a question. This is Donna Pinto, and thanks, Deanna, for the shout out. Appreciate that.
Of course.
Great presentation. Thank you very much. One of the biggest questions, and I'd say topics in these online groups that I hear quite often is about natural alternatives to tamoxifen. And I don't believe there's anything been studied on them, but there's a lot of talk about xenoestrogens and phytoestrogens and reducing estrogen and being ideal body weight, and then doing everything you can to reduce the toxic load and your potential, if you are ER positive, so naturally. And I wonder if you could, talk about that at all, any knowledge you have of that.
Yeah, it's not only a question I'm sure in the online forums, but it's a question that I get asked in clinic all the time as well is, well, I'm on a low estrogen diet and I'm exercising and I'm getting my weight down and all of these other things. The problem is none of that right now is a substitute for our anti-hormone therapy, our endocrine therapy for breast cancer. And part of the problem and part of the challenge is when tamoxifen and aromatase inhibitors were studied, they were studied in broad patient populations. So a patient may say, yes, but I'm doing everything on my end, maybe tamoxifen, maybe I don't need it. And that's possible, but we have no data. And so unfortunately for now, I certainly encourage healthy behaviors because all of those things, to eat better and to minimize toxic load and to exercise to reduce inflammation and maintain an ideal body weight, those will all certainly help reduce recurrence risk. They will all also help reduce the risk of heart disease, which kills more women in this country than breast cancer. So I want to just put a plug in for everything that you already know to do will help. But we don't know if that's enough. We don't have any data, and unfortunately, I don't know if that will be studied in the rigorous way that it needs to be in order for us to be able to say, okay, if you do X, Y, and Z, then we know that tamoxifen is not going to add any benefit to you. And one of the reasons I don't think it'll be studied that way is because lifestyle interventions in general are very hard to study. And the other is just because of funding and lack of funding, really, just a global lack of research funding. And certainly to study things that are a little outside the box, I think that's very challenging. So unfortunately for right now, I think we're kind of stuck with the medications that we have, encourage the healthy behaviors, but we don't know if those healthy behaviors really are enough.
Well, sort of piggybacking off of that, do you recommend any complementary approaches to help with the side effects of tamoxifen or aromatase inhibitors?
Yeah, there's a lot of, and I will make it very clear that I'm not a big proponent of alternative therapy, meaning instead of, but I am a big proponent of various complementary therapies. Some of them actually have not been well studied. Some of them have been well studied. There are a lot of criticisms of many of the studies of yoga and acupuncture and some of the other treatments. But most of these complementary therapies come with minimal to very low side effects. And I certainly think that it is worthwhile to look into some of these treatment options because, especially in patients with higher grade disease or those that may be at higher risk for recurrence, or have other risk factors such as a strong family history or genetic mutation, we want to try and maximize the ability to stay on the medication. But the only way we can do that is make sure quality of life is maximized as well. So I think, first of all, looking at some of the very basics, exercise, and it doesn't have to be marathon training. It can be going out for a walk 15 to 20 minutes a day. And little things add up. Improving diet, decreasing alcohol intake. A lot of these can also help with some of the side effects of the medication, such as hot flashes, which can be tied or can be made worse by a high alcohol intake, and sometimes in women who are very overweight. So doing the stuff to take care of yourself first, but then looking into some of these complementary therapies, especially those that are associated with low side effects, I think is very, very important.
What is the current thinking on extending the length of aromatase inhibitors past 5 years with regard to D?
Yeah, so with regard to DCIS, both tamoxifen and aromatase inhibitors were still at 5 years. There is data on both pre and postmenopausal women with invasive breast cancer on extended endocrine therapy, stronger data in the premenopausal women than in postmenopausal women. But for DCIS, for the most part, it's 5 years of treatment. We're not yet recommending 10 years.
And I think it came out of San Antonio last year, the idea of using lower dose tamoxifen.
Yeah, so lower dose tamoxifen is really interesting. So it was presented as an abstract at San Antonio, and the full paper was published earlier this year in, I believe, in Journal of Clinical Oncology, JCO. So this was a study done in Italy, and what they did is they took women that they considered high risk. So kind of like our old STAR trial, which was the prevention trial, and that's how we found that raloxifene was just as good as tamoxifen to reduce the risk of breast cancer. So they took women who were high risk. But interestingly, in Italy, they considered low-grade DCIS as high risk. They, unlike the US where we would consider that DCIS or breast cancer. So they took women that were high risk based on atypical hyperplasia and low-grade DCIS, and they randomized them. This is also the interesting point. They randomized them either to low-dose tamoxifen, 5 milligrams a day. Normal dose of tamoxifen is 20 milligrams a day, versus placebo. So that would be a very hard study to do in the US because we don't like to randomize patients with something we consider cancer to placebo. So they randomized them either low-grade, low-dose tamoxifen or placebo, and they found that the low-dose tamoxifen gave close to a 50% reduction in breast cancer development. And that's the same risk reduction we see from 20 milligrams tamoxifen. And there was really no significant difference in side effects of low-dose tamoxifen to placebo, meaning the patients did really well on low-dose tamoxifen. So it's been interesting when this study came out, or shortly after it did, I had the opportunity to hear a presentation by Professor Craig Jordan, who is known in some circles as the father of tamoxifen. And he actually talked a little bit about how when these drugs were developed, unlike how it's done for a lot of chemotherapy agents, where they start off as what's the maximum tolerated dose, and they do dose response curves. Can you get the same effect with a lower dose? That really wasn't done with tamoxifen or the aromatase inhibitors. It was just, does it work or doesn't it work? And so part of the problem is we don't know if lower dose tamoxifen is actually just fine. And so this study was relatively small, but at least it provided us with some evidence that for risk reduction, low dose tamoxifen is just as effective as standard dose. We have no data on DCIS treatment or invasive cancer treatment as far as low dose tamoxifen, but it's very interesting questions. Again, like I said, research funding, the pool of research dollars is shrinking day by day. And so this unfortunately may not be a study that's done, but I think it raises a lot of very important questions, not only about can we use lower dose treatment, but just a lot of questions about how our drugs are developed and approved in general, and how that process maybe is not done as ideally as it could be.
I had done a support call with someone who had said that their doctor recommended, because they were having some issues with tamoxifen, to take the 20 milligram every other day.
Mm-hmm. Yeah, there's a lot of, we don't know what's, if that's okay. We don't have data on that, but many of us, and I'm a breast surgeon, but I work very closely with my medical oncologist, we will often find that patients do well potentially splitting that 10 milligrams in half and taking half in the morning and half in the evening. And sometimes it's just they're not getting that full load of medication all at once, and their side effects are a little bit less. In patients who are really having horrendous symptoms, we will try an every other day scenario. Again, we don't have data, and we certainly caution the patients that we don't know if this is just as effective, but on some level, it's possible that it's better than nothing. So the first thing I usually recommend is cutting the pills in half. So at least you're getting the full dose in a 24-hour period. And then if that's not effective, certainly you have to talk to your oncologist, because it's very individualized, but we do have a lot of patients that find improvement in their symptoms if they alter their treatment schedule a little bit.
Well, let's say somebody was diagnosed with DCIS and they had surgery, either a mastectomy or a lumpectomy, and they elected not to go on endocrine therapy. And then like 4 years later, could they decide to go on it?
Yeah, so first thing is, if you have a mastectomy for DCIS, we often don't recommend endocrine therapy because unlike with invasive cancer, where the endocrine therapy is not only working to reduce local recurrence in the breast, but also working to reduce the risk of metastatic disease, in DCIS, we're primarily focused on just the breast alone. Now, you could certainly make the argument that if you have a unilateral or just one side mastectomy, tamoxifen may provide, or endocrine therapy may provide some protection for the other breast, but we often don't recommend endocrine therapy with a mastectomy. But if you are diagnosed with a recurrence 4 years later, then yes, we would recommend endocrine therapy at that time. And the fact that you didn't take it for 4 years doesn't mean that you can't take it if you develop a recurrence. If you go 4 years with no treatment, and then you all of a sudden say, I think I want to start, even though everything's been clear, that's a little less, it's a little more questionable of whether or not there's a real benefit there. And that would certainly be a case-by-case discussion with your oncologist.
During the course of the 5-year treatment, can you take a break, a 30-day, 60-day, 90-day break?
So there's nothing in any of the studies that have been done that endorse that, but I will say that is very, very common. We just completed a research survey looking at endocrine therapy use, and we're analyzing the data, and there are many, many women who say, I don't take my medications when I go on vacation. I took a break when it was my daughter's wedding because I didn't want to be having hot flashes as the mother of the bride and things like that. And of course, many people that are having side effects, their oncologist will recommend stopping treatment for a period of time and then either restarting a different medication. So I am not endorsing taking treatment breaks as a blanket recommendation, but I can say it's commonly done, and most oncologists do understand that as well. So I would encourage women to talk to their oncologists about potential short treatment breaks, or potentially switching medications, because even among the aromatase inhibitors, even though they're all a similar class of medications, some women may have more side effects with one medication versus another. So these are things that, like I said, commonly done, not a blanket recommendation, but definitely talk to your oncologist about it.
Do these drugs affect recurrence in the same breast or the other breast or both?
Both. And that's one of the important things to realize, is that lowering estrogen levels or blocking estrogen from getting into the breast cell not only reduces the risk of the index cancer, the cancer you're dealing with now, not only reduces that risk of coming back, but it reduces the likelihood of a whole nother cancer, either in that or the other breast, from developing. So I think that's important to keep in mind when women are really struggling with the medications and trying to decide, is this worth it? It's more than just the one cancer coming back. And again, we know that in a percentage of patients with DCIS who develop a recurrence, up to 50% of those recurrences could be invasive. And so it's not just, I hear a lot, well, if it comes back and it's DCIS, what's the big deal? Because that's not a threat to my life. But the reality is the recurrence could potentially be invasive cancer as well.
How long does the protective benefit last?
That's a really good question, and I don't think we have great answers to that. It's probably at least 3 to 5 years, if not longer. But this is what we're starting to see with late recurrences of invasive cancer on endocrine therapy. So, typically or historically, we used 5 years of endocrine therapy for invasive cancer, and we see patients with recurrences 15, 20 years down the line. So the protective effect probably doesn't last 15 or 20 years, but it's probably a minimum of 3 to 5, if not a little bit more.
Does endocrine therapy make the breasts less dense?
It can over time, yes, especially the aromatase inhibitors. Tamoxifen, not necessarily, because women who are on tamoxifen, they're generally premenopausal, and so they can have their normal estrogen levels. But aromatase inhibitors, the combination of going through menopause on its own, that naturally can lead to decreased breast density. But the combination of the aromatase inhibitors, the combination of going through menopause plus the aromatase inhibitors, which shut down any residual estrogen production, that can definitely lead to a decrease in breast density over time, which can potentially lower risk of disease, but also can make mammograms more sensitive the less dense the breast is.
And how does tamoxifen affect pregnancy? How long would one have to wait after stopping tamoxifen before trying to get pregnant?
We don't really have great answers to that question either, because historically we've told women who have had breast cancer, don't become pregnant. And lo and behold, many of them did, and we have now data showing that their outcomes in terms of disease recurrence and survival are no worse. There's actually an ongoing clinical trial now looking at interruption of endocrine therapy, interruption of tamoxifen for pregnancy. And they recommend a several month washout of tamoxifen. I think it's I don't want to misquote, but it's at least a month, if not a little bit longer, washout for tamoxifen. I can follow up on that and get back to you on it, so you have accurate information. And I'll get you the clinical trial information as well.
Thank you. My last question would be, are there any vitamins, herbal supplements, or foods that should be avoided while people are taking tamoxifen or an aromatase inhibitor?
For supplements, I generally recommend to avoid soy that is not in real food form. There's a lot of controversy about soy because of its estrogen-like properties. Real soy in real food form, and I've heard Susan Love say soy hot dogs are not real food, so you want to go to the source. In moderation, so a few servings a week is probably fine. But soy supplements or soy protein powders and things like that, probably not a great idea. Again, lack of data, but the more highly processed the ingredient, the less like its natural state it is. As far as other herbals and supplements, not a lot of data out there. There's more information as far as chemotherapy, where they recommend avoiding antioxidants and things like that that may potentially interfere with the chemotherapy medications. And as far as foods, really nothing that's a standard recommendation. I personally think if you can get most of your vitamins and nutrients from foods, and avoid the supplements altogether, that's obviously the ideal. It is not always possible, but there's not anything major on the list. I mean, we just recommend a good, healthy diet, and the things like the chocolate cake and the extra glass of wine, save those for the special occasions in moderation.
Other questions for Dr. Attai?
I have another question. This is Donna. You mentioned about the 50% reduction, and that's something that I always try to explain. That's more of a relative risk. And so if you're low risk, it makes a difference at your risk level that you start out with, right? So maybe you could just talk about that.
Yeah, so when we talk about risk reduction, risk is a really hard thing to get across, because to the individual patient, it's either 0 or 100. Either your cancer comes back or it doesn't, right? But the only way we really can explain it, because we don't have personalized recommendations, like I said, all those tests to try and sort out recurrence risk, even the genetic ones, the genomic ones, they're not crystal balls. But if your risk of recurrence is relatively low, say you had 5 millimeters of low-grade DCIS that's estrogen positive, it's grade 1, it was a tiny area, and you are postmenopausal, say you're 75 years old, your risk of local recurrence is probably well under 10% over the rest of your lifetime, even if you do nothing. Whereas if you are 40 years old, or let's say 35 years old, with 5 centimeters of high-grade cometonecrosis DCIS, and you have a family history of breast cancer or other risk factors, your local recurrence risk without any additional treatment may approach 40 to 50%. So whether your local recurrence risk is 10% or 50%, 50% risk reduction from taking endocrine therapy is going to be a big difference. It's going to knock you down to either 5 or 25. But that going from 5 to 10 versus, or 10 to 5 versus 50 to 25, those may be very different decisions for those two individual patients. So Donna, you're absolutely right. When a physician says Tamoxifen can reduce your risk of recurrence by 50%. The next question should be, what is my risk of recurrence? So then you can put those numbers into more absolute terms for yourself, and you can make a decision that is as much as possible based on your individual scenario, not the scenario of all the women diagnosed with DCIS.
Great. Yeah, thanks for explaining that. I think that's an important point that
and
gets lost sometimes with.
It gets lost often, and because risk, honestly, even for physicians, is hard to understand and hard to explain. But it all comes down to dialing it back to the individual patient. And 50% risk reduction, if you don't know what your risk is, it's kind of like 50% off sale, right? If the item costs $2,500, 50% off is still a lot of money. So it really makes, you want to try and make it as individualized and as unique to your situation as possible.
Touche. Well said.
Does anyone, we just have a couple minutes left. Does anyone else have any questions for Dr. Attai? This is your chance. She's at the top of the breast cancer field. She knows lots and lots. So here's your chance.
You were about to say everything and I was going to stop you. So.
Well, yeah, no one knows everything, but I mean, this is your chance to really be able to ask somebody that's very highly respected in the field, very knowledgeable, and you might not get this opportunity again. So please ask.
Yeah, this is Robin from New York. I do have a question. A few minutes ago, you mentioned raloxifene versus tamoxifen. When would raloxifene become an option or an appropriate choice for a patient?
So, excellent question. Raloxifene, the brand name is Avista. I'll give just a little bit of history. Raloxifene has been used for a long, long time by the OBGYNs because it can help treat osteoporosis. And years ago, it was noticed that the women who took raloxifene for osteoporosis seemed to have a lower likelihood of developing breast cancer. And the chemical structure is a little bit similar to tamoxifen. And so I alluded to earlier the STAR trial. This was a prevention study led by Dr. Patty Gans, who's a medical oncologist, really leader in the field of endocrine therapy, especially side effects. But they compared tamoxifen and raloxifene head to head in a double-blinded placebo-controlled study. So, or a double-blinded study. So patients and the providers didn't know which drug they were getting. And what they found is that both had an equal reduction in the development of invasive cancer, but raloxifene had fewer side effects and also was better for bone protection. Now, and so for women at high risk who are postmenopausal, we can use raloxifene for risk reduction, and we often do. Now, one of the things that got buried a little bit in the STAR data is raloxifene was not as good as tamoxifen as far as DCIS reduction. So, but it was just as good as tamoxifen for invasive breast cancer reduction. The problem is raloxifene is only approved by the FDA right now for risk reduction. It is not approved for cancer treatment. And as long as we consider DCIS a cancer, and again, that is changing, raloxifene is generally not recommended. We certainly have patients with both DCIS and invasive cancer who do not tolerate tamoxifen or the aromatase inhibitors, but really are motivated to take something where we will use raloxifene, but we certainly caution the patients if it's considered off-label use, and we don't have data on whether or not it's just as effective in terms of treatment in these patients.
Thank you.
You're welcome.
Well, sadly, we've reached the end of the hour. I want to thank Dr. Attai for sharing her time and her knowledge with us. This was just fabulous. Goodness knows everybody's, as they go through their DCIS journey, and if they're estrogen receptor positive, this is what's facing them, and there's a lot of questions. So we thank you for helping people try to figure out, you know, what to do as they go forward.
Absolutely, my pleasure. I really appreciate you having me, and I have here on this last slide my email address. Obviously, I am not all of your doctors, so I can't give direct medical advice for your condition, but if there's any questions that didn't come up, send them to Deb and she'll send them to me, or you can reach out directly, and I'm very easy to find on Twitter as well.
Thank you very much.
My pleasure.
Thanks everybody for attending. Our next roundtable will be met Wednesday, November 20th, when the topic will be how to stay healthy during the holidays. It's all luck. Thank you very much.
Thanks, Deb. Thank you, Deanna.